menopause and hormone replacement therapy. menopause سن اليأس أو بحبوا يسموه سن الأمل marks the end of a continuum of declining ovarian function and ushers the aging process. You note that life expectancy of women has been increasing over the past 150 years, and while menarche is attained earlier, the age of menopause remains unchanged. Increasing longevity means that the present-day woman can expect to spend nearly 40%, that is 1/3 of her lifespan after the menopause. This is why it is important to understand the pathophysiology, the changes of menopause, and how to approach problems of menopause. Menopause does not occur suddenly, and this is why there are a few terms for you to know. Menopausal transition starts from the time when ovaries start to fail till the last menstrual period. It lasts on average for 4 years. It can be shorter in smokers though. And it starts on average at the age of 47.5 years. And 10% of women will not go through the menopausal transition and will stop having their menstruations suddenly. Perimenopause or the climacteric is the period from the time when the ovaries start to fail till 12 months after the last menstrual period. Menopause is the last menstrual period, and this is clinically diagnosed by having 12 months after the last menstrual period. Postmenopause, time after complete cessation of menstruation, whenever menopause is diagnosed, with no periods, with amenorrhea for 12 months. Primary ovarian insufficiency, when menopause occurs before the age of 40. We can call it also premature menopause. The average age of menopause is around 51 years, plus minus 2 years. Earlier menopause before the age of 45 may occur in some women, especially if they have family history of early menopause, in women with type 1 diabetes, and in smokers. At the age of 54, 80% of women will be at least 1 year post-menopause, and this is why we have inadequate data about women who are still menstruating by the age of 54. We expect the majority to be menopausal by that age. Premature menopause or premature ovarian insufficiency is when menopause occurs before the age of 40 years, and the incidence is really low, of around 0.1% before the age of 30 and 1% before the age of 40. The cause of spontaneous ovarian failure in these patients is usually unknown. This is why when you discussed secondary amenorrhea, one of the differentials was premature menopause. Premature ovarian insufficiency, which was called in the past premature ovarian failure, is a complex and relatively poorly understood entity. It can be either spontaneous or induced. Spontaneous premature ovarian failure is most likely idiopathic, but other causes can be present as genetic, like Turner syndrome, 45XO and mosaic, enzyme deficiencies as galactosemia, 17-alpha hydroxylase deficiency, autoimmune disease, infections as TB, mumps, CMV, and malaria. And there is the induced premature ovarian insufficiency where surgery was done. Both ovaries were removed by lateral oophorectomy, and in cases of chemotherapy, especially those that cause that they are toxic to the ovary as alkylating agents and radiation exposure. It is important to diagnose premature ovarian insufficiency, which presents usually as with symptoms similar to those of menopause, but also cycle irregularities, primary, secondary amenorrhea, as I said, and also primary amenorrhea. Once we diagnose premature ovarian insufficiency, we have to start immediately hormone replacement therapy because of the possible consequences of ovarian failure at earlier age than 40 years. The transition from the reproductive years through perimenopause and menopause is a complex endocrine process which can be simplistically summarized by estrogen deficiency. So it is an estrogen deficiency state. If you remember that a female has a certain fixed number of primordial follicles that declines throughout life without replacement. In a newborn female baby, there are 2 million primordial follicles, which are reduced to 300 to 400,000 follicles at puberty. During her 40s, only few thousands are left, and few or no ova at all in postmenopausal females. The two critical landmarks in the ovarian failure process include decline in fertility and then changes in the menstrual cycle with a shortened follicular phase, which affects the length of the cycle. So initially we may start by having shorter cycles and later on longer cycles. As we said, the main pathophysiology of menopause is a state of estrogen deficiency. With decreased number of follicles, there will be reduction in estradiol and inhibin B. Initially, there will be a compensated failure with increasing FSH, follicle stimulating hormone, which stimulates the remaining follicles to produce estradiol more rapidly. This leads to shorter cycles. Then FSH fails to stimulate estradiol production, resulting in decompensated failure when there is very low number or no follicles. At that time, follicle stimulating hormone will be 10 to 20 times higher than the baseline. LH rises to a lesser extent and estradiol levels drop. Without a follicular source, the larger proportion of postmenopausal estrogen is derived from the ovarian stroma and adrenal secretion of androstenedione, which is aromatized to E1, estrone peripherally. Estrone is biologically less active than estradiol. Estradiol is the most important estrogen in the reproductive years, while estrone E1 is the estrogen of postmenopausal women. The peripheral conversion to estrone results in low levels of E1, which is far below what used to be during the reproductive life. Also, testosterone would have dropped by 50% by the time of menopause. In summary, all gonadal hormones are measured at a very low level after the menopause. This is to show you the hormonal changes in the perimenopausal area, premenopause in the first 5 years and more than 5 years since menopause. Organ changes occur because of the lack of estrogen. You note shrinkage and atrophy, decrease in the size of the ovaries, thinning of the cortex, atrophy of the fallopian tubes. The uterus will become smaller with a body to cervix ratio 1:1. Thin and atrophic endometrium. This can be a cause of postmenopausal bleeding because of atrophy and scanty cervical secretions. The vagina will become narrower due to loss of elasticity, and the epithelium will become flatter, paler in color, and with an alkaline pH. Atrophic vulva, flat labia, scantier pubic hair, changes in the breast fat, changes to the bladder and urethra, and loss of muscle tone. All of the changes because of lack of estrogen. You can see the picture on the right is in a premenopausal woman, while on the left this is a uterus of 1:1 body to cervix ratio postmenopausal woman. Clinical presentation of menopause is due to the lack of estrogen, as we said. It is convenient to classify symptoms chronologically into acute, medium, and long-term symptoms. Note that some of the medium symptoms could appear even before the hot flushes have been established. And there is rising evidence that even bone loss may start occurring before the last menstrual period, before menopause. Acute clinical manifestations include changes in the menstrual pattern, as we explained, shorter cycles or longer cycles that end by cessation of menstruation completely. Hot flushes and night sweats are vasomotor symptoms. These affect 70 to 80% of women, with the median duration about 7 years. Hot flushes are frequently distressing for some women, may interrupt sleep, and this results in tiredness and irritability. They are usually self-limited and become less intense and less frequent with time without treatment within about 5 years. Other symptoms include mood swings, panic attacks, depression, forgetfulness, and difficulty concentrating, in addition to headaches. Medium-term symptoms usually occur 5 to 10 years after menopause, and these include vaginal dryness and dyspareunia, reduced libido. This could be either due to dyspareunia or testosterone deficiency. Raised vaginal pH leads to or contributes to recurrent UTIs, atrophic urethritis, changes in the urogenital tract leading to urinary symptoms, in addition to changes in skin and hair, and aches and pains all over the body. Long-term health implications include mainly osteoporosis. And after the age of menopause, there is progressive increase in cardiovascular disease. However, the direct relationship with estrogen deficiency has been questioned, and the aging process per se is considered responsible by some. It is unclear if dementia is associated directly with estrogen deficiency. But estrogen deficiency is associated with increase in body weight postmenopausally and body fat redistribution to the abdomen. This body fat redistribution is independent of weight gain, and it is also an independent risk factor for cardiovascular disease, type 2 diabetes, and breast cancer. What is established as a direct cause of loss of estrogen in postmenopausal women is that these women are less able to conserve collagen, and this woman is less able to maintain a healthy endothelium and less able to synthesize neurotransmitters, which affects cognition, leads to irritability, low moods, and insomnia, in addition to panic attacks and palpitations. Women with menopausal symptoms may present before the actual age of menopause. Hot flushes may present in the menopausal transitional years rather than after the actual menopause. We start by advising on a healthy lifestyle, diet, and exercises as running, walking, swimming, or practicing yoga, in addition to diet modification, as we said, reducing the stress. Understanding the physiology of menopause on its own may help the patients or help women understand what they're experiencing. Psychological support is important, as I said, by explaining the physiological changes. Psychological support is also required by family members, mainly by the husband or the partner. Hormone replacement therapy is one of the options, and there are alternatives to HRT. There are prescribed and non-prescribed medications which are under the category of alternatives to HRT. The women with premature ovarian failure, or those with gonadal dysgenesis, or who have surgical or radiation-induced menopause resulting in premature ovarian insufficiency and menopause, those women should have hormone replacement therapy as soon as possible when they are diagnosed, to avoid symptoms of menopause and the long-term consequences of menopause and estrogen deficiency, mainly osteoporosis. And these women are not at risk or increased risk of breast cancer as compared to women receiving HRT at the natural age of menopause. We start HRT for this special group of women from the time of diagnosis and continue till the expected natural age of menopause. Hrt types include either estrogen only. Actually, estrogen is the important part of hormone replacement therapy. But there are combined regimens where progestrogens are added in the presence of the uterus to protect the endometrium. Sequential and combined and continuous combined regimens with changes in estrogen and progesterone concentrations during the cycle. We have the synthetic steroidal alternatives. Livial is a trade name. Tebilone is the scientific name. This medication has estrogenic, progesterogenic, and weak androgenic activity. It is converted in the endometrium to a metabolite without estrogenic activity. So it is safe for the endometrium. And when women take this HRT, Livial, they will have a bleed-free HRT. So no, they will not have any periods. But this can be an advantage for some women, while others consider this as a disadvantage. It is important to remember not to give Livial before the actual diagnosis of menopause. Other types of or other regimens of HRT can be given before the actual age of menopause. Testosterone is another type of HRT which can be given to manage reduced libido. Again, this is giving estrogen, cyclical or continuous estrogen and progesterone in the presence of a uterus, or sequential combined with and without free intervals, sequential and continuously combined, different regimens and preparations. Routes of administration include oral and non-oral routes. Oral, transdermal, intravaginal, cream, ring, and intrauterine Mirena coil. There are advantages and disadvantages for every route, and it is the patient's preference to decide which one to use. Usually the oral is the first choice and its cost is acceptable, with a beneficial effect on cholesterol, HDL and LDL, and the total cholesterol, but high doses are required with variations in absorption. Those with lactose intolerance cannot use the tablets because all of them contain lactose, and there is effect on liver protein synthesis, so there is increase in triglycerides. The patches and gel, the transdermal route, avoid the gut and liver breakdown, and this is why lower doses are required, but they are more expensive with less side effects on gallbladder disease and coagulation factors. Mirena can be used as a backup or to protect the endometrium when estrogen is used, and if it is used as part of hormone replacement therapy, we can keep it in only for 4 years. We have the estradiol implants, subcutaneous implants, and vaginal estrogen preparations. With the local vaginal estrogen, we do not need to give progesterone to protect the endometrium because the absorption is locally and systemic absorption is minimal, and there is no concern for endometrial protection. These are some of the indications for non-oral route. Benefits of HRT: first, reduction of vasomotor symptoms, and estrogen is very effective for the treatment of hot flushes and vasomotor symptoms, and the improvement is usually noted within 4 weeks. Mood or sleep disturbances will usually improve with HRT by alleviating the vasomotor symptoms. Hormone replacement therapy has a direct effect on low mood, irritability, and anxiety. Improvement of the genitourinary symptoms. Usually the maximal improvement with estrogen takes around 1 to 3 months of treatment, but may take up to a year of hormone replacement therapy. This must be explained to the patient because these women usually expect rapid improvement with hormonal therapy. Long-term therapy may be required. There is also reduction in the risk of osteoporosis and reduction in vertebral and hip fracture. Decreased risk of colorectal cancer was also observed. Risks of HRT. The absolute increase in risk is small, and the extra number of cases of each of the following conditions associated with hormone replacement therapy is typically smaller than the health risks associated with smoking or obesity. HRT increases the density of breast tissue on the mammogram, and this is why we need to have a baseline mammogram before starting HRT. Estrogen on its own does not increase the density of the breast tissue on mammogram, and tibolone has a limited effect. HRT is not a single class of hormones, as we said. We may have estrogen only, progestogens, combination, and tibolone. Progestogen addition increases the risk of breast cancer compared with estrogen alone, but this has to be balanced against the reduction in the risk of endometrial cancer, because estrogen has a bad effect on the endometrium while progesterone protects the endometrium. Tibolone also increases the risk of breast cancer, but to a lesser extent than with continuous combined hormone replacement therapy. The risk of breast cancer increases with the duration of use, and there is no increase in the risk of breast cancer in women who start HRT for premature ovarian insufficiency. Increased risk of endometrial cancer in cases of unopposed estrogen and the presence of a uterus. So if there's a uterus, we have to give progestogens to protect the endometrium. Increased risk of venous thromboembolism. Usually the risk increases in the first year of a hormone replacement therapy, combined HRT, with estrogen and progesterone. The effect is more than estrogen only. The risk does not increase with non-oral estrogens. There is also increased risk of gallbladder disease. This is mainly with oral, and this is lower with transdermal preparations. Uncertainties concerning HRT with coronary heart disease, stroke, dementia and cognition, ovarian cancer, and quality of life. Different studies have different results, so uncertainty regarding these issues. Please go back to the NICE guidelines to look at the summary of the risks associated with HRT. During the hormone replacement therapy consultation, it is important to discuss the decision with each woman on an individual basis. You take her history, risk factors, and her personal preferences. And once you explain menopausal changes and the possible options of managing menopausal symptoms, prescribed and non-prescribed medications, and start by explaining the lifestyle changes before giving hormone replacement therapy. Not all postmenopausal women will require HRT. Some will have well-tolerated symptoms, while others will have distressing symptoms. For these women, in the presence of studies doubting the safety of hormone replacement therapy, doctors stopped prescribing HRT. And this is why the Royal College of Obstetricians and Gynecologists had a statement in 2004 to advise doctors to continue to prescribe HRT for women if they have significant symptoms, but on the condition of explaining the risks of the management, and it is the woman's final decision, patient-informed decision to take hormone replacement therapy. But for those with premature or premature ovarian insufficiency, HRT should be prescribed until the natural age of menopause. And again, there was another statement in 2011 by the International Menopause Society recommending to continue prescribing HRT when indicated. And women can have the option, provided we explain risks and benefits, starting by the lowest effective dose, and we keep reviewing the woman to decide when to stop HRT. In the consultation session for HRT, we have to discuss certain issues. Make sure that HRT is suitable for this patient. Start by taking a menstrual history. Is this lady still menstruating or not? As we said, vasomotor symptoms may start before the actual menopause. And if she's still menstruating, what is the pattern? If she's menopausal, when was the last menstrual period? Check for possible contraindications, and you can use the mnemonic ABCDE and abnormal uterine bleeding, active liver and renal disease, breast cancer, cardiovascular disease, deep vein thrombosis, and endometrial cancer. Abnormal uterine bleeding is an absolute contraindication for whatever hormonal treatment, combined hormonal treatment. You can use the same mnemonic for combined hormonal contraception. Take a family history of cardiovascular disease, osteoporosis, thromboembolic disease, breast, bowel, and ovarian cancer. Personal history, risk factors for coronary heart disease as diabetes, hypertension, smoking, obesity, lifestyle, and family history of myocardial infarction and stroke. Risk factors for osteoporosis. And what does the patient want? Does she want hormone replacement therapy? Is she aware of alternatives to HRT or not? And always take the chance to discuss healthy lifestyle options, diet and exercise. On physical examination, you need to document the body mass index and blood pressure. Breast and pelvic exam are indicated if there is personal or family history that necessitates that. Otherwise, the only requirement is to have a body mass index and blood pressure. What investigations do we need before starting hormone replacement therapy? No investigations are routinely indicated for the diagnosis. Follicle stimulating hormone is not really required to diagnose the natural menopause. You rely on the symptoms and age of the patient, while if this is premature ovarian insufficiency, you have to have serial FSH. You need 2 readings confirmed to be higher than 30 international units per liter to say that this is menopause. Also, in premature ovarian insufficiency, first of all, you need to rule out pregnancy, think of a thyroid function, and appropriate investigations. For menopause at the natural age, as I said, we do not need follicle stimulating hormone. You may need thyroid function based on the history. Mammogram is required because, as I said earlier, combined hormonal therapy will cause changes in the density of the breast tissue and on mammogram, and this is why you need a baseline mammogram for follow-up. Otherwise, you wouldn't be able to tell, was this essentially present, or is this the effect of HRT, or is it really abnormal? If there is any abnormal bleeding, endometrial sampling is indicated. Abnormal uterine bleeding is a contraindication to start hormonal replacement therapy. So if at any time there is abnormal bleeding, don't start HRT, investigate, and part of the investigation will be endometrial sampling, as we discussed earlier. FSH should not be done in women using combined estrogen and progestogen contraception or high-dose progestogen, because we're going to have false FSH readings. Once hormone replacement therapy is started, bring the lady back first after 3 months, then after 6 months, and then annually to check blood pressure, for breast examination, vaginal examination only if indicated, and for pap smears as indicated. If there are any problems, you can advise the patient to come in earlier. We don't really need lab tests to diagnose perimenopause and menopause. Perimenopausally after the age of 45 can be diagnosed based on the presence of vasomotor symptoms and irregular periods. Having said that irregular periods may occur, this does not mean not to investigate abnormal uterine bleeding perimenopausally. If it is just minimal irregular bleeding, acceptable, that's fine. But if it is heavy bleeding, intermenstrual bleeding, postcoital bleeding, please, you have to investigate. Menopause in women who have not had a period for 12 months and they're not using any hormonal contraception. So 12 months after the last period, this is definitely menopause. If without a uterus, the patient had a hysterectomy for whatever indication and the ovaries were preserved, then you rely on the symptoms. Premature ovarian insufficiency, as we said, clinical presentation in addition to elevated FSH on 2 samples. Don't rely on one result to diagnose premature ovarian insufficiency. Factors that influence prescribing HRT are the presence of a uterus, because we said estrogen is the hormone that is needed for hormone replacement therapy. In the presence of the uterus, you cannot give estrogen alone because you want progesterone to protect the endometrium. The presence of the uterus necessitates combined HRT or addition of Mirena to protect the endometrium. The other factor is the patient's preference to go for oral or non-oral preparation based on preference and medical history. If HRT is started and there are side effects, then you encourage women to continue HRT for at least 3 months, as most of the side effects will resolve with increased duration of use. Side effects of HRT, systemic HRT, are related to either estrogen or progesterone. Estrogen-related side effects tend to occur continuously but sometimes randomly in the cycle. Fluid retention is more likely to be due to progestogen component. Bloating, breast tenderness or enlargement, nausea, gastric upset may be helped usually with by taking the HRT with food or switching to transdermal preparations. Leg cramps can improve with lifestyle changes, including exercise and stretching of the calf muscles. Headaches are common, and for all persistent side effects, the solution will be to decrease the dose of estrogen, change the estrogen type, or change the route of administration. Progestogen-related side effects tend to occur in a cyclical pattern or may be present continuously. To decrease the side effect, what we usually do, we reduce the dose and duration, change the type, change the route, change to continuous combined therapy. Fluid retention and headache are due to either estrogen or progestogen. When we have this, we start by modifying the progestogen component. With breast tenderness, we go for lower estrogen doses. If irregular bleeding or breakthrough bleeding occur while on combined HRT, this requires investigation as postmenopausal bleeding. Weight gain is not proven in randomized controlled trials. What are the alternatives to hormone replacement therapy? Alternatives to HRT is what we start with usually when we manage menopausal symptoms. Starting by lifestyle modification, changes in diet, advising women about regular exercise, swimming and running, lighter clothing, sleeping in a cooler room, reducing stress. These all may be sufficient to manage hot flushes. In addition, avoiding possible triggers as spicy foods, caffeine, smoking, and alcohol may help. Non-pharmacological agents that we use, gels or for vaginal symptoms as the repellents. This will replace vaginal secretions, causes rehydration to the vagina, and improve vaginal symptoms. Pharmacological agents as progestogens, but with progestogens, the potential risks to the breast need to be taken into account when using progestogens, and the doses that are required to achieve vasomotor symptom control increases the risk of venous thromboembolism. Clonidine is a centrally active alpha-2 adrenergic agonist, and its value is limited because of its side effects. We have selective serotonin reuptake inhibitors, fluoxetine and paroxetine, and selective noradrenergic receptor inhibitors, venlafaxine. These are effective in the management of hot flushes, and probably this is the medication to start with. Antiepileptic gabapentin was found to relieve hot flushes. Complementary therapies are used by women often as they are perceived as being safe options. Phytoestrogens are produced by plants and they bind to estrogen receptor, trying to activate it, but only with partial activation. And it is you can get it from diet. Long list of possible sources as oats, barley, wheat, sunflower, chickpeas, kidney beans, vegetables as red onions, broccoli, tomatoes, sweet peppers, garlic, long list. Herbal remedies are not under strict control. They may have interaction with conventional therapies, and this is a major concern. Whenever you take a history of abnormal bleeding at any age, please ask about the herbal remedies women take. Other interventional therapies as acupuncture, hypnotherapy, reflexology, these were not studied against estrogen-containing medications. Vitamins such as vitamin E and C and minerals as selenium are present in various supplements, and the evidence that they are of any benefit to postmenopausal women is limited. Osteoporosis will be covered in your orthopedic rotation. Just to remind you that especially women with premature ovarian insufficiency should be treated by estrogen to prevent osteoporosis. We do not have evidence to screen all postmenopausal women for osteoporosis, and management is usually based on the presence of risk factors. Treatment is usually by lifestyle changes, exercise, weight bearing, as walking, diet modification, and medical treatment includes bisphosphonates. We do not give hormone replacement therapy to treat osteoporosis. The special group of patients with premature ovarian insufficiency or premature menopause, as previously called, we have to start hormone replacement therapy as soon as possible once the diagnosis is made. We continue HRT, as I said earlier, till the expected age of natural menopause. If you have a lady, for instance, who had premature ovarian failure at the age of 28, you start HRT and continue till the age of 50. The importance of HRT is to control menopausal symptoms, vasomotor symptoms, maintain sexual function, and minimize the risk of cardiovascular disease and osteoporosis, possibly Alzheimer. Oral contraceptive pills may be used to control the symptoms, but no long-term data on the protection against osteoporosis and cardiovascular disease, as HRT is usually higher doses compared to oral contraceptive pills. Just a reminder, with local estrogen, we do not need to give progesterone for endometrial protection.